Hi guys, my name is Dr. Asim and I'm here with the first of a kind teaching video by Plabable. It's a small initiative to help you guys in clearing your concepts and upgrading your knowledge with the right amount of content that you need for your Plab exam. So to begin with, the three high yield topics from the many that I have picked from endocrinology are diabetes insipidus, syndrome of inappropriate ADH secretion, and hyperaldosteronism. Trust me, it's gonna be a very busy day at the clinic. So let's see who is our first case. So our first case is a 40-year-old woman who comes to you with complaints of increased thirst for the last 5 weeks and increased trips to the bathroom. She has bipolar disorder and hypertension, and her family history is significant for diabetes, and she is so worried that she has diabetes. On further questioning, you find out that her bipolar disorder medication was recently changed a few weeks back. So, what's the most likely cause for her symptoms? Now, before we give a diagnosis to this patient, we would dive into our first topic, which is diabetes insipidus. So, let's get started. As you can see on the screen, diabetes insipidus is characterized by deficiency of antidiuretic hormone, whereas syndrome of inappropriate ADH secretion or SIADH is characterized by excessive production of antidiuretic hormone. Now, this antidiuretic hormone, which is hanging in your posterior pituitary, is synthesized in the hypothalamus, secreted from the posterior pituitary. It goes and it acts on the V2 receptors in the kidneys, in the renal tubules specifically, and they cause retention of water and passing of concentrated urine. Now, what happens is if there is deficiency of this hormone, or if there is deficiency of antidiuretic hormone or vasopressin, so the renal tubule cells, they become impermeable to water and the person starts to pass large amount of diluted urine, resulting in polyuria. Now, if you want to classify diabetes insipidus, you can divide it into two broad categories, the central and the nephrogenic. Now, anything that's messing up the brain will lead to central diabetes insipidus, whereas if there's anything which goes wrong with the kidneys will lead to nephrogenic diabetes insipidus. Now, in the central cause, there is complete deficiency of production of antidiuretic hormone. So there is no antidiuretic hormone at all being produced. Whereas in the nephrogenic one, there is presence of antidiuretic hormone. The hypothalamus keeps on producing, and the posterior pituitary keeps on releasing antidiuretic hormone. But it is unable to act on the kidneys, on the V2 receptors of the kidneys, due to the resistance of the receptors. Now, both of these causes, they result in passage of diluted amount of urine, because in the absence of antidiuretic hormone, the cells of the renal tubules, they become impermeable to water, so they are not able to retain any water, reabsorb any water, and it leads to passage of very diluted urine, resulting in polyuria. Now, if we look at the causes of each of these types, in central we have tumors, trauma, and infections. In tumors like craniopharyngioma, trauma if a patient has sustained head injury, or infections like tuberculosis and sarcoidosis. Now, in nephrogenic, we have if the patient has chronic kidney disease or the patient has renal tubular acidosis, because these are the conditions which damage the kidneys, which damage the cells and the V2 receptors where the ADH acts. Now, one very important cause of nephrogenic diabetes insipidus, which you would never want to forget for the exam especially, is lithium. Now, patients of bipolar disorder are put on lithium, and so they are particularly at a very high risk of developing nephrogenic diabetes insipidus. Now, you must be thinking that how would such a patient present to you? The patient, because of deficiency of ADH, the cells are impermeable to water, so the patient, or if there is deficiency of ADH in this, like in the central, so basically what is happening that the patient is unable to retain water or reabsorb water. So the patient will have polyuria, and because of polyuria, the sodium concentration in the plasma goes up. And this is sensed by the osmoreceptors, and the osmoreceptors, they activate the thirst center, and the person starts to drink more and more water. Now, if a patient has polyuria, so this naturally makes sense that the patient will also increase his intake of water. So there's polyuria and polydipsia. Now, due to polyuria, the person will get up in the night, in the middle of night, to pass urine. So it leads to noxuria as well. So this is one of the clinical features of diabetes insipidus. Now imagine you are sitting in your endocrinology clinic and a patient comes in and you are suspecting that this patient has got diabetes insipidus. So your initial investigation would be to measure the 24-hour urinary volume in such a patient. And you would notice that their 24-hour urinary volume often exceeds more than 3 liters per 24 hours. Now, after you are pretty sure that this patient has got diabetes insipidus, so you order a confirmatory test. The confirmatory test is your fluid deprivation test with response to desmopressin. Now, what's this fluid deprivation test? I have seen so many people getting confused with the fluid deprivation test. So let's crack the code behind the fluid deprivation test. Now we have two persons here. One is a patient with diabetes insipidus and one is a normal person. Now we restrict the fluid intake in both of these persons. And what we see in a normal person is that when the amount of fluid which he is consuming goes down. So what happens is that his plasma becomes concentrated. Now when the plasma becomes concentrated, so ADH is released because it is sensed by the osmoreceptors that the plasma has now become concentrated and the amount of sodium in the plasma has gone up. So the ADH is released, and once ADH is released, it acts on the renal tubular cells to retain and reabsorb water. So the person starts to conserve water, and the amount of urine which he was passing now goes down, and the urine osmolality rises. Now we have a second patient here, the person who has diabetes insipidus. Now in this patient, when you restrict fluid intake, so the plasma becomes concentrated, but either ADH is not released, as in the case of central diabetes insipidus, or if it is released, it is not able to act on the kidneys due to the resistance of the receptors, as in the case of nephrogenic diabetes insipidus. And when the ADH is not functional, so the kidneys are not able to conserve or retain or reabsorb water. And as a result, despite the fluid intake which has decreased, the person still continues to pass large amount of diluted urine. And the urine osmolality remains low, which is less than 300. So the normal urine osmolality is between 300 to 800 milliosmoles. Now, after you have confirmed that this patient has diabetes insipidus, now you would like to know whether he has central diabetes insipidus or whether he has nephrogenic diabetes insipidus. Now you give desmopressin to this patient, in which you have confirmed that he has got diabetes insipidus. You give desmopressin, and once you give desmopressin, this desmopressin is a vasopressin analog. It goes and acts on the receptors in the kidneys. If the receptors are functional, this desmopressin is able to function, is able to work, and is able to conserve water if it is able to act on the receptors in the kidneys. But if due to some reason, as in nephrogenic diabetes insipidus, the receptors are not able to function properly, so this desmopressin which we have given from outside is not able to act on the kidney and is not able to conserve water. So the patient continues to pass large amount of diluted urine. So in a nutshell, I can say that if you give desmopressin, and if the patient, even after giving desmopressin, continues to pass large amount of diluted urine, the patient has nephrogenic diabetes insipidus, because the desmopressin has not acted on the receptors. And if after giving desmopressin, the patient has started to conserve water and the urine osmolality has started to going up, and the urine volume has decreased. So this is a case of central diabetes insipidus, where the receptors earlier were functioning, but only ADH was deficient. Now once you are given ADH, the receptors are able to sense that ADH and reabsorb water. Now if you move on to the treatment of these conditions, we would see that the drug of choice for central diabetes insipidus is desmopressin, because the problem here is deficiency of ADH. And if we see in the patients of nephrogenic diabetes insipidus, the drug of choice is thiazide diuretics. Now you would be surprised to know that thiazide diuretics actually cause more diuresis, more passage of urine. So why are we giving thiazide diuretics in a patient of diabetes insipidus? But they have a paradoxical effect here. Now, these thiazide diuretics, they go and act on the distal convoluted tubule, and they prevent reabsorption of water. And also there's absence of ADH. So the person is already passing large amount of urine, and plus you have given diuretic. So the person is still further passing further the volume of urine which he was passing has increased. But as a compensatory mechanism, the proximal convoluted tubule cells sense this thing which is happening in the distal convoluted tubule, and they cause reabsorption of water. So the proximal convoluted tubule sense this situation and they start to reabsorb more and more water as a compensatory mechanism, and hence thiazide diuretics are the drug of choice. Now, in case even if after giving thiazide diuretics the person is passing large amount of diluted urine, polyuria is persisting, then you give NSAIDs. So NSAIDs, what they do is they prevent the dilatation of the afferent vessels to the kidneys, and so the GFR decreases, the amount of fluid which is coming to the kidneys decreases, and they cause symptomatic improvement. Another very important thing that you need to keep in mind in patients of nephrogenic diabetes insipidus is that if there's any underlying condition, you need to treat that. Suppose most of the patients who are on lithium are particularly at high risk of developing this condition, so you need to stop the offending drug. Now, if we go back to a clinical scenario where the patient presented with polyuria and increased thirst, and she was recently started on a new medication for her bipolar disorder. So I think now you would be able to give this patient a diagnosis, and the answer here is she is suffering from nephrogenic diabetes insipidus. So our next patient is a 41-year-old male who presents to the emergency department with headache of severe intensity. He also has hypertension and recurrent kidney stones. On examination, you find that he has a stiff neck and pain. Labs were done and revealed a serum sodium of 131 millimole per liter. What is the single most likely mechanism behind his serum sodium results? Now, let's find what this patient has. Now our next topic is syndrome of inappropriate ADH secretion, or SIADH, which is opposite of what we have just talked about, that is diabetes insipidus. Now, as we know, diabetes insipidus is characterized by deficiency of antidiuretic hormone, whereas in syndrome of inappropriate ADH secretion, there's excessive production of antidiuretic hormone, which leads to concentrated urine and retention of a lot of amount of water in the distal renal tubular cells, which leads to systemic fluid overload and hyponatremia. Now, the electrolyte abnormality which we saw in diabetes insipidus was hypernatremia because the plasma was concentrated and the sodium concentration went up because the person was passing diluted urine. Whereas here in SIADH, the patient is retaining water, he's passing concentrated urine, and hence there is dilutional hyponatremia. Now, the point to note here is that this hyponatremia is not due to the deficiency of sodium, but it is due to dilution of the plasma. So if we look at the causes of this condition, it can be an excessive production from the pituitary gland itself, or it can be excessive production from an ectopic source, like in the case of paraneoplastic syndromes, and particularly the patients of small cell cancer of the lung are at high risk of developing SIADH. Depending upon the severity of hyponatremia, whether it's mild, moderate, or severe, the patients can present anywhere from fatigue, nausea, vomiting, muscle aches, and even to seizures and altered consciousness. But when you examine such patients, despite fluid retention, despite fluid overload, systemic fluid overload, you find that these patients do not have edema. And the mechanism behind that is that whenever there is systemic fluid overload, there is increased venous return. Now there is increased amount of blood which is going to the right atrium, so the atria are stretching more than usual, which leads to release of atrial natriuretic factor. Now, natriuretic means release of sodium in the urine, natriuresis. So there is increased sodium release in the urine, which leads to passage of water as well. However, it is not as much as in diabetes insipidus, but still it is enough to maintain a euvolumic state. Because we know when sodium is passed in the urine, so sodium is osmotically active and it draws water along with it. So hence these patients do not develop edema despite fluid overload. Moving on to the treatment for these patients, the first line of treatment is fluid restriction. You restrict their fluid intake to prevent further loading of fluid in the systemic circulation. And if this fails, then you treat them with ADH receptor antagonists, drugs like tolvaptans and demeclocycline. Now moving on to a patient whom we just saw has presented with a headache of severe intensity, which points our diagnosis towards subarachnoid hemorrhage, and also the labs reveal hyponatremia. So, one very important association of subarachnoid hemorrhage is syndrome of inappropriate ADH secretion, which you would want to remember for the exam. And so, hence these patients, they develop hyponatremia. So that was all for these ADH disorders. Now, hyperaldosteronism is the topic that we'll discuss in the second part of this video.